Good morning.
Mic. Use the mic, please.
Well, I'm going to talk briefly about vaporization of the prostate. Now you can hear me. I'll talk briefly about bipolar vaporization of the prostate. First, like vaporization of the prostate at a rural setup. The reason I'm presenting this paper is that the practice of urology in Kenya seems to be limited more to the urban centers, and very little goes on in the periphery. We have 47 counties. About 7 counties, only 7 counties, people are able to do therapy. In Nairobi, you have about 7 hospitals, major hospitals, where you're able to do therapy. Of the 7 major hospitals, they have rudimentary equipment for doing therapy, even on vaporization. This equipment was acquired a long time ago, and the urologists have to use their own equipment to be able to be safe and effective for the patient. Let's see what I do. Over the last 1 year, all the patients blood outlet obstruction due to prostate enlargement, which conforms to benign prostate enlargement, are subjected to vaporization of the prostate. I've done more than 126 patients in that period of time. The mean hospital stay is 2 days. I operate on you today, you go home tomorrow, and I don't do blood irrigation in these patients. None of the patients have been subject to transfusion, and of course, the periphery blood issues are very sensitive. You don't have blood banks, and you don't have to struggle to get blood for the patient. And none of these patients have the clot retention. One patient had irritative symptoms, which are resolved within 1 month. You have to bear with me that the biggest fear with vaporization is that patients have irritative symptoms. But these are subjective, and most of these patients tend to respond even without analgesics within the period of 3 months or so. That's the current equivalent, not the one about 10 years ago. The mean volume of normal saline used is about 15 liters per patient, and this costs about 8 to 5 Kenya shillings. Economy is very important when you operate on patients because the cost of surgery is a 99 Kenya. 825 shillings per session is less than the price of 3 liters of pure soap, which you want to use in Nairobi when you're doing the normal therapy. All the surgeries under spinal anesthesia last an average of 5 minutes. The reason why we take shorter period is that when you are doing bipolar vaporization, the vision is excellent, there's minimal bleeding, and we should use continuous irrigating, rotating outer sheath. So you really don't have to empty the blood every now and then, and there's no impairment of the vision. So you're able to do it in a very short time. So the actual cost of doing a TURVP, this R should not be there. TUVP, that R should not be there. A 3 doctor's fee in my center is around 8,500 shillings. That comes around US dollars, $100. You can cost what you do in Nairobi and the actual cost of the patient. The electrode I used for this surgery lasts 5 cases. But at times you can even do up to 7 cases with 1 electrode. Of course, the ones who sell say that should be only used once. Average cost that I'm not interested in this, I'm not being financed by anybody. So what I'm going to give is basically what I do, not biased to any institution or financial institution or any manufacturing company. According to literature review, therapy remains the treatment of choice for prostate enlargement despite the well-known complications. I'm sure everybody knows the complications you get when you do therapy. It's often referred as gold standard procedure, but why? This is based on historic facts. It's not the current practice of therapy as it is today. Because what was being done 30 years ago is not what you're doing today. The alternative surgical procedures can be developed to avoid the mobility associated with therapy, and I'm sure you know all of them. TUVP can be achieved with either laser energy or electrosurgery. That is, you can vaporize the prostate with either laser or electrosurgery. Laser is out of reach for many institutions and is not cheap. And the learning curve is also very low. Vaporization is a simple as therapy, there's not much difference, there's no learning curve. TUVP allows tissue removal with minimal blood loss and at a lower cost than therapy, as I've seen. And bipolar therapy has been practiced over a decade or by decade, and the studies have shown that it's safe and effective. Now, there's a difference between bipolar therapy and bipolar TUVP. When you're doing bipolar therapy, you resect. But when you're doing vaporization, you don't resect. There's no tissue you can get for histology. Both provide good hemostasis, low complication rates, and a very reduced cost of procedure. And I think where you can save a coin, you must be a very happy man to the patient that you sell. It's safe for patients with pacemakers, bleeding disorders, and those on coagulation therapy because of good hemostatic function and the good vision when you're doing the surgery. This is an element. I'm just showing this. There are about 3 types of working elements. This is one of the companies I'm using. And you can understand that because it's bipolar, it has two electrodes. There's a passive electrode and an active electrode. Now, that is active electrode, and that is the passive one. In therapy, you only have this electrode itself for the high frequency cable. But now, that is the one we are using. Now, that is the bipolar vaporization electrode. It looks like a mushroom. If you check the surface area of that ball, it's wider than the laser fiber. So you're able to vaporize a bigger area than if you're going to use ohmium laser to vaporize. But the results will be almost the same. Now, this is a bipolar loop. If you want to do the resection, that's the loop. You can see there's a yellow one, that's the active one. If you remember the therapy, they're the same color. So there's active and that's the return. Now, these electro settings, that's a diathermy. You appreciate that when you're doing vaporization, you usually use very high setting. I'm sorry, I can't see that. That's around 270 setting. In normal therapy, you use about 130 or so. And the reason to set that is to be able to vaporize the cells without a lot of jarring. Now, this is the vital signs of a patient who had did QRFP, that actually should be there. And the reason I put that is that when we are treating patients, operating the patient, and in a spinal anesthesia, more than not, the nurse does some ever-drain on the side, because the pressure tends to go down very fast because of bleeding with QRP, which is not the case with the vaporization. Now, that is what you test, which you always do after you have done your QRP to see whether the flow of effluent is satisfactory enough you have been able to create a good channel. The reason I put this slide is that both QRP and the TUVP, you create a prostatic fossa, but still a bit of the prostate tissue remains behind. Enucleation is different. So you can comfortably compare QRPP and QRP, but you can't compare this with what? Enucleation in terms of the symptomatic relief. Now, that is the effort of the patient of the procedure. You can see how the urine, how clear the urine is. If you do QRP, it's not likely going to be able to get that kind of clear urine. In the sense that this patient may not even require catheter, only that he was under spinal anesthesia. The other procedures to QRP are many, and one of them is lesser enucleation or lesser vaporization. The reason lesser enucleation and vaporization is not very common is two. One is the learning curve, and three is the cost involved. And I think in Kenya, we opened one center where someone can be able to talk of lesser enucleation. And above it all, again, the enucleation, you have to modulate the prostate. When it comes to modulating, you need to modulate the blood, and also the intestines, they're not very careful. So that makes it a bit tricky, and the learning curve is not very short. But it's a very good procedure. It's been known that it's superior even to therapy and even the vaporization by bipolar vaporization. Bipolar resection and vaporization of the prostate is cheaper and it has no learning curve. Now, transurethral microtherapy and needle ablation are fallen short because you know that reintervention of this procedure is very high, so it's better to the therapy. Prostate stents are reserved for just the very moribund patients and not very commonly used. Of course, the other methods are available. Now, these are the basic principles of vaporization, what it goes on there. I don't need to go through this. All you need to know is that when you're doing vaporization, the mushroom loop doesn't scoop like you are resecting. It just comes to close contact with the surface of the prostate gland, and it vaporizes the glandular tissue, and you have minimal chance of operating the capsule, unlike when you're doing a therapy and getting a stabilization. So it's quite a safe procedure. Now, one thing I have to appreciate is that despite all the improvement on equipment and the technical principles behind therapy, over the last 80 years, the side effects of comorbidities have not changed a lot because of the fluids we use for irrigation. These fluids are not very cheap, and the two, we are at risk of the Tourette syndrome, which nobody likes it at all. What you need to appreciate is that when you are doing vaporization, there's very little tissue penetration beyond where you want to go, about 50 to 100 micromillimeters. And this is very minimal compared to what used to be there with the monopolar vaporization, where you're getting tissue penetration of more than a centimeter and getting very severe irritative symptoms. That's why we don't have a lot of symptoms with bipolar vaporization, because the tissue penetration is limited to about 50 to 100 micrometers. Now, with the recent equipment, you're able to combine both the vaporization and resection in the same sitting. So if you still want tissue for histology, you're able to get a few chips for histology, then you vaporize after that. And in so doing, you're going to save on time, and you're going to be able to get some specimen you want to do for histology. However, before operating on patient, we always screen them for prostate. And then the patient who has featured with a tendency handled a different way. I've already said this is next. What you can say is that the current practice that you're able to complement for the vaporization resection, or you do one of them and you save on the cost of the patient, time of the surgery, and the complications. Evaluation by HPS and quality of life index are similar whether you do bipolar vaporization or therapy. There's no difference between the two, they are the expert. The post-operative peak urine flow, that's the Qmax, and the post-rescue volume are also the same, whether you've done vaporization or the normal conventional resection. The efficacy of TUPP is very close to therapy, and both procedures leave similar prostate cavity, so they are expert. So the question is, why have not changed up to today? Together, the reduced cost per procedure, that's compared to laser. This makes bipolar attractive technique, you go to setup. The transient dysuria observed is a result of inflammatory drug. Complications. I'm sure we know the complications of the therapy and the anal procedure there. We know the hematuria and the UTI, and these are common in therapy. Globally, the operative complications are lesser with the TUPP. Next. Intraoperative complications which involve bleeding and the rest and Tura syndrome are less frequent with the TUPP than that. Late complications, you're talking of blood neck contractures and strictures and any stenosis of some kind. And we know that these are lower with the TUPP. However, I want to comment on strictures. The sheath, you are using the size of the sheath, and your technique contributes a lot on whether the patient is going to develop strictures or not. I won't done this for a year. Strictures don't develop within a year. Maybe they'll come later, but it's for instance 60, a bit very small. Blood neck contractures are also before the surgical skills, and if you are minor or not. So these ones I've not seen them because I've just started using the other day. So TUPP, what you know is that has a higher rate of transient dysuria, and that's why I said that has been the fear, at least for a short time. Yes. So, conclusion, clinical evidence indicates bipolar vaporization is effective and safe, minimally invasive technique that provides very good hemostasis control and low complication rate. Suitable for use in high-risk patients, that's those patients with pacemaker and the rest. And the catheter removal is earlier in TUPP than therapy. The mean operation time for TUPP is shorter than therapy, that's worldwide. But the equipment used for both procedures cost almost the same. I think we should be more flexible to offer the best safe procedure for the patient and the cost effective. I think these are the questions to ask ourselves. So what is the gold standard treatment for enlarged prostate? Is it still therapy? Is it vaporization? Is it an enucleation? Is it water ablation? I don't know. But what determines the surgical outcome? Is the urologist himself, the equipment he's using, the method he has used, the venue he has done the surgery, or his techniques? Are we conservative or to medical engineers? Because what you have done over years don't seem to be changing. And that's what we enjoy carrying our briefcase one place to the other. Thank you very much.
Okay, done most of the thing, you take it out. And when we do the transurethral sonography after a few days, we see the transitional zone popping up. He may not have the symptoms. So normally you can have a transitional zone and you can have a good flow also. But our experience when we compare to the TURP, there is no guidelines how much to restrict. Where is the end point? Unless the visual picture is, but still I feel it is a cheaper, it is a good one compared to the laser prostatectomy. Thank you.